Renteria here with me on our Wednesday call, so I'm not going to do this complete justice like she did yesterday, but I'm going to go through what our plan is, and then if you guys have any questions, we can take it to her after. So I just wanted to go through kind of sorry, and I'm also like have a little bit of a cold, so sorry if I sound weird. But I wanted to go through kind of our hierarchy from our causes of death. The major event form has been updated, and it should be released, I'm hoping, this week. And I'm updating it with a new form guide too. On that form, you're going to see these updated, this list of causes of death for both the primary and now what we're going to be calling contributing versus secondary causes of death. And this is in our hierarchy order as we have determined for magic. So this list is it's bigger than the previous one, and we're hoping it helps cover some of the more common things that we've seen. And we've expanded on some of them. For instance, relapse progression is now relapse progression, stable disease, and persistent disease, depending on the type of disease the patient was transplanted for. These additional terms might make more sense. Acute GVHD, chronic GVHD, infection. So one of the rules of the hierarchy is if the patient has relapsed or progressed or has persistent disease, that would probably be considered the primary cause of death. But I also want to stress that there are definitely exceptions to this. I think determining cause of death is a very complicated, complex thing. I had people that could send me examples of autopsy reports, of notes around the time of death, and I encourage people to keep doing that so that we can work together to sort of streamline. Of course, in doing that, you see how complicated it is to determine cause of death. If you have an autopsy, if you don't have an autopsy, of course, that could become even more difficult. But pretty much you want to stick to this line of causes. What else do I want to point out on here? So these last few ones, other transplant-related, other non-transplant-related, and unknown. These have now been sort of siphoned out to be a little clearer. You'll get a specify box that will pop up with this. So you'll want to indicate those. Unknown really would be if a patient passed away and you just have no information at all. For infection, if this is selected, you'll also see a specify box, and what that means is we want to know what organism was identified, what is the infection the patient passed away from. So what some things you want to look for? Definitely the autopsy report, and at least this is the way it is here, and I'm assuming maybe it's similar over in Germany, but these reports take a long time to come back. Yeah?
It's endless.
Yeah, and not everyone requests one. Sometimes, it's obviously a very difficult time. So sometimes family members don't want one because they're kind of just done. But if they do request one, it might take some time. And so what we could do on the form is you could put placeholder information. You could save the form as a work in progress. There is going to be an added comment box. So you can definitely elaborate more, like pending autopsy results. And then just, go back to the form when you have those results. If you don't have that, then looking at a hospital discharge summary, look to why was the patient admitted? What were they being treated for? This might help target into the cause, but also they might have been admitted for one reason and then something else happened, and that's what actually caused the patient death. And then these are just some sort of questions to answer. Has the patient relapsed? Are they being treated for GVHD? Are they on a taper of steroids for GVHD still, for acute or chronic? And then are there any infections? So those are the main ones. And then I cannot stress this enough, to review every single cause of death with your PI or designee, which for some of you are that person, but I think it's always good to review it because it's really difficult sometimes to know what has happened. Um, Yesterday, Ann and I were talking about, um, you know, having an open conversation about these things. So if you ever want to send over a redacted source documents and have a discussion about what our thoughts are, I mean, I'm sure you do this at your site, but maybe you don't have access to that. Um, you're always free to send it to us. And then I wanted to sort of talk about some things that would not make sense to put as a primary cause of death. Um, Things that I've seen in the database, and that were discussed with Anne here, who's our cause of death guru. So anemia, malnutrition. Um, I saw someone write the word disease. I wasn't sure what that meant. Um, CNS failure, it's a little vague. Does that mean there's a bleed in the brain, or what exactly does that mean? Acute respiratory failure, something caused that to happen. What was that? And then I saw this acute deterioration and small bowel obstruction. So that's way too many to be listed as a primary cause of death. Really, it needs to be pinned down to one thing, and then all of these other things could be listed in the contributing cause. Um, so those are just some examples.
So Rachel,
Yeah.
if I think of acute respiratory failure, I mean that's something I can easily, or we've experienced once patients are on the respirator and then they have those different issues like GVHD, virus infection, and maybe some sort of additional vasculitis, you can't really discern anymore. So at some point, family decides not to increase respiratory support and let the patient go. So you wouldn't find out then what the, I mean, the patient dies of acute respiratory failure and
Mm.
multiple issues. So what do you put in?
So I would say if you have any of the other, I would say, hierarchy items present, um, and there's a case to say that would be the cause of death. So if you do have acute GVHD present, um, that would then fall under the hierarchy of, in this case, primary cause of death, and then maybe you could make a note in the comment box about no data really to say what caused this, but you could definitely add your thoughts to that, but still put acute respiratory failure if there is no further information. But like I said, the hierarchy exists to sort of help. But if, for instance, you feel that, in this case, acute respiratory failure is the cause of death, that is what led to it, that maybe these other things that were present were not contributing, or were so minimal, and you
They're
feel that
probably contributing, but they are all contributing. So
yeah.
to put it in a way, which one is the one cause of death can be tricky.
So then this is when the hierarchy could help you. So if the patient has relapse disease, the thought is that is sort of the catalyst for these other things occurring. And then with the GVHD as well, and down the list. But obviously each patient is going to be unique. But if you have a case where all of these things are occurring, I would go back to the hierarchy. Okay.
Again.
Sorry?
I couldn't hear you the last 60 seconds, but that's fine.
Just basically, I said that you should always return to the hierarchy if
Right.
multiple um, events are existing, and then this could help sort of determine that. I would say use the hierarchy unless you feel strongly that the hierarchy does not apply for your patient. Did I come through that time?
Yes, I had.
Okay.
Yes.
Okay, good. Um, the last one, so we got sent a case from Mass General that was really interesting, and it was a 63-year-old patient who was transplanted for CLL and had a past medical history of hepatitis C. Um, she had sent us this autopsy report, and it wasn't clear from that report what ultimately happened, and I'm sure that this is what happens all the time when you're reading a path report. Um, there was multiple items listed, including that the patient had relapsed. The order wasn't clear. There was never a final diagnosis listed in it, even though it said so, final pathology diagnosis, and then had all these things. They had included these comments, which really create like this rich picture of what was happening with the patient. But even though it still wasn't clear. So in this case, even though the patient had relapsed, they had this encephalitis, and the cirrhosis of the liver really is what, an HHV6 infection. So that really is what we would call for this patient's cause of death versus the relapse in that case. And so this was just an example of course, an exception to our hierarchy rule. But I do think most cases do follow the hierarchy. So this was meant to be really brief and sort of just scrape the surface of it and really kind of focus on what this hierarchy is to kind of alert you guys that this is coming out. I'm hoping by the end of the week, so tomorrow, as well as with a form update, a form guide update. And then I thought we could continue this sort of like series of mini training sessions, including kind of maybe more in-depth case analysis of causes of death, and sort of to show people, because I think it's more difficult for some coordinators than others to sort of decipher what's going on, and maybe their comfort level with their physician, and wanting to ask those questions, and still a few like they're that they're listened to. So that was kind of what I wanted to start to do, and maybe have some other topics that we discuss at the end of these calls, and hopefully not take up too much of people's time, but sort of help everybody in their learning process with GVHD and BMT and all of that. So does anybody have any questions about anything we went over?
Oh, perfect for the moment.
Okay. All right. Well, if you do think of something, or if you want to sort of bounce ideas off of us, I would say please email myself and Anne Renteria, and I can send out her email with that as well. But she was in, when I called for examples, her email was in that there. So otherwise, that's all I have. So I hope everyone has a good day. I guess you guys are done with your day, maybe.
Almost, yeah.
Well,
A few hours to go.
I am jealous because my day is just starting.
Yeah. Just starting. So have a nice day, hopefully.
Yeah, thank you so much. Oh, yeah. Thank you, guys.
Bye.
All right, bye.
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 Bye.